Next, we're going to do our head-to-toe baby assessment. The first thing you're going to do is you're going to look at the color of your baby. Our baby is nice and pink. Our baby is not gray or bluish. Our breathing, we can see our breathing is nice and rhythmic. Jenny's looking at our breathing. Our breathing's great. We're not experiencing any grunting, retractions, or nasal flaring. So our baby looks good there. And then in our airway is clear. Obviously, our color is good as well, so we're nice and pink. So that's good. That's the first thing you're going to do is ABC when you come upon your baby. Next activity is our baby awake or sleeping. It looks like our baby might be sleeping, but we're about to get our baby up a little bit. Our posture is either flexion or extension. Our baby looks like it's pretty much, our knees are nice and flexed, our arms have some flexion. So our baby does not look limp. That would be very upsetting if our baby was in extension or was flaccid, but our baby looks nice and flexed. Our cry, we would want to evaluate our cry. We want a lusty, low pitch, and vigorous, very loud cry. A weak cry or no cry can be very distressing. So the first thing Jenny's going to look at is skin lesions. She's going to look, and she can see, she's looking on the head. She sees something on the eye, and that would be a stork bite, little dilated capillaries, completely fine, telangiectatic nevi. She also sees some little bumps on the nose, little white bumps, and those are called milia. And those are completely normal. Those are just little collagen collections in the pores. And now she sees a red area with a white indurated space, and that's newborn acne. This newborn acne can be stressful to moms, but it is a normal finding. It is a normal finding. Okay, now she's looking on the back. She sees a red spot on the neck, and that would be stork bite as well. And that's completely normal. And now she's looking for a Mongolian spot. And Mongolian spots are just in mature melanocytes, and usually they're found on the buttocks of the baby. Usually darker skinned babies are a little bit lighter at birth because they do not have mature melanocytes, but usually as they darken, the Mongolian spot will fade because the rest of the skin is darker. So now Jenny's looked. Jenny doesn't see a yellow tinge baby. To check yellow tinge, Jenny's going to blanch the forehead or the chest. And if it's yellow underneath, that could tell us that our baby is yellow tinged. She is obviously wearing gloves, but she can feel through her gloves if our baby is warm. And then she's going to look in the mouth to see if the mucous membranes are moist or dry. Dry would definitely be upsetting. Jenny also looks at the skin to see how thick the skin is, and we can't see any veins on our baby, which is awesome. So we can say our skin is thick, and if it's peeling, we're not so concerned. Jenny's also looking for lanugo, which is the fine hair. Usually we see it on the shoulders, on the back, between the scapula. And so now we can see that our baby is mostly bald, which tells us that our baby is mature. Since this is a newly born baby, Jenny's also going to look for vernix around the neck, behind the ears. It's usually in these little folds. And this is the white. It looks a little bit like cottage cheesy. We call it baby lotion. They have it in their elbows, usually stuck in there, under their armpits. And the more vernix they have, the younger they are. The less they have, usually the older they are. We've already talked about milia, Mongolian spots, stork bite, and then Jenny's going to look at the length of the fingernails. Usually at term their fingernails go all the way to the end of their fingers. One important thing to note here is that we don't want mom to use little scissors because the fingernail is attached to the cuticle and it can cause the fingers to bleed. They should use an emery board until the baby is at least 6 months old to prevent bleeding with filing or trimming of the nails. So you should always file them. Hair distribution. Jenny looks at the hair, and this baby obviously doesn't have any hair, and that's okay. But they have different types of hair, and some will have a lot of hair and some will have little, and it doesn't have anything to do with heartburn. That's definitely a myth. Okay, so the next thing we're going to look at is the head. And so now Jenny's going to inspect the head. She's going to sit the baby up. You want to sit the baby up, Jenny?
Sure.
Yeah. Just a little easier to look at. So now we got our baby sitting up, and we can just look at our head. And we're looking to see, is it round, is it oval, is it molded? And our baby's head looks pretty nice and round, doesn't it, Jenny?
Mm-hmm.
So I would tend to say this is a C-section baby, wouldn't you?
Yes. No capit.
No capit, which is fluid that crosses the suture line. Usually with babies who've gone through the vaginal canal, their head has, obviously their suture lines are open, and their head has the ability to mold to get through the pelvis and to be able to come out vaginally. So most vaginal babies have a significant amount of molding and sometimes capit or fluid, which is completely benign. And it's you can see where Jenny's pointing to the back, and it's just a little bit of fluid accumulation that crosses the suture line. Jenny's now checking for a supple hematoma, and usually that's on one side or the other. It does not cross the central suture lines. So Jenny will show you that right down the middle is the suture line, right down the middle. And you don't want it to cross because you want the fluid to cross because that's just fluid. A supple hematoma is going to be isolated on one side or the other. Many times with a supple hematoma, unfortunately, there will be a lot of bleeding under there. And what's significant about that is that those ruptured red blood cells will increase your bilirubin level because you already have a baby who's at risk for elevated bilirubin. A normal baby is. And then now you have more injury and you have more red blood cells that are trapped under the skin. So the vasculature has to dilate and pick that up, which will raise the bilirubin level. Now Jenny's going to check the anterior fontanelle, and it is a diamond shape, and it should be nice and flat. Is yours flat, Jenny?
It's flat.
Yeah, nice and flat. You should not, now if it bulges when they're crying, that's okay. But if it's bulging and they're not crying, that definitely is a serious sense of concern where we start to worry about ICP. Jenny's is nice and flat, which is awesome. It's not depressed or sunken, which could indicate to us that there's a dehydration issue. Now Jenny's going to check the posterior fontanelle, and that's right here in the back, and that is triangular shape. And is it nice and flat, Jenny?
Nice and flat.
Okay, awesome. Again, we don't want it to bulge, only unless the baby's crying, and usually back there they won't bulge, but flat is what we want. Jenny's now going to palpate the suture line. These are the bones, and we want them to either be open or overriding, meaning they're sitting on top of each other as they were pushed together as the baby was escaping the pelvis. So overriding or open is what we want. Fused is never good. Fused sutures means that the baby's brain cannot grow. So you want to make sure that those are nice and open. Jenny's looking for any lesions on the head. Sometimes we have lesions from suction. Sometimes we have lesions from a C-section where they did the incision and were a little heavy-handed and it lacerated the baby's head. And so we don't see any lesions or anything like that. Now, next Jenny's going to sit the baby back down and look at the neck and move the head back and forth to make sure that our neck is nice and supple. Nice and supple. So she's just moving the head back and forth and making sure that we have nice mobility of the head. Our baby, there we go, Jenny. And the reason why we want to do that is we want to make sure that we don't have a fused neck, or we don't have any cervical injuries, or that we don't have a short neck or wide neck or anything that can be associated with a chromosomal abnormality. All right, next Jenny's going to look at the eyes, and she's going to look for epicanthal folds. And epicanthal folds is a little piece of skin that covers the tear duct. Now this is completely normal in Asian populations, but it can indicate the risk for chromosomal abnormality if we see it in a non-Asian population. Jenny's checking for discharge, and doesn't look like her baby has any discharge, does it,
Nope.
Jenny? Looks good. Sclera, are your sclera nice and white, Jenny? No hemorrhages?
Nope, no
Yeah,
hemorrhages.
No hemorrhages, very good. And we know that our baby had erythromycin for eye prophylaxis to prevent blindness for chlamydia and gonorrhea. Next, Jenny's going to check the ears. She's going to actually look at the ear canal first and make sure that we have a nice ear canal. She's looking for budding, little buds of skin, or little dimples or sinuses, which could indicate to us a malformed ear canal. And do you see any, Jenny?
Nope.
That one looks good. And that
Looks
one as
good.
well. So now the position of the ears, Jenny's going to draw an imaginary line from the outer canthus of the eye to the top of the ear. And we can see that that's a nice straight line. And that would tell us that our ears are not low set, and that is a positive finding. Low set ears may be indicative of a chromosomal abnormality. Now Jenny, it's going to be difficult for her to check the amount of cartilage on our baby's ears because our ears are really stiff, but you would take your ear and you would pull it back and you'd see how quickly it recoils. So a very early baby has no cartilage and it's just skin, and that skin would just stay folded, whereas our baby has very, very thick cartilage, so we know our baby is older. Jenny's now going to look at the nose for patency. Babies are nasal breathers. The reason why they're nasal breathers, you can see she's putting her finger in the baby's mouth. Flip your finger upside down, Jenny, so they can actually see. Yeah. So she's going to put her finger in the baby's mouth and gently touch the baby's roof of her mouth to get the baby to suck. If the baby can suck, and that means the baby is breathing. So the babies are nasal breathers so that they may breastfeed. That's how they get their oxygen while they're breastfeeding. They're nasal breathers. Now she's going to look in her baby's mouth, look at the color of the mucous membranes. Nice and pink, right, Jenny?
Nice and pink.
Nothing yellow tinged, no Epstein pearls, and Epstein pearls are normal collagen collections. Jenny's going to take her finger and feel the roof of the baby's mouth to rule out a cleft palate. And then, Jenny, how are your lips? Are they nice and symmetric? They're vertically and horizontally symmetric?
Yes.
Oh, look good. All right, great.
No tongue tied.
No tongue tie. Okay,
Underneath
good.
the-
So the tongue is nice and mobile,
Mm-hmm.
and the frenulum does not extend to the end of the tongue?
Nope.
Okay, very good. If it did, Jenny, we would call breastfeeding support, right? Because
Yes.
that could create a big problem. Okay, so chest and lungs. We've already done our respiratory rate. Everything looks good. Our rhythm is pretty regular. And our breath sounds. So now Jenny's going to auscultate our breath sounds. And we always want to do the apices and bases. So for our babies, we're going to listen in the upper aspects and in the lower aspects. That's on the anterior. Now we're going to roll our baby over or sit our baby up. Yep. And we're going to listen on the back of the baby in the uppers and the lowers. And Jenny, did you hear any crackling?
No crackling.
No crackling. So babies who come through the vagina, they get the nice vaginal squeeze, which pushes out the extra lung fluid into the third space. So usually they have pretty clear lungs if they are term. Babies who are C-sections do not get that squeeze to push out that lung fluid, so they may have crackles up to 3 to 4 hours after delivery. So that's one of our big risks that we have with C-section. So Jenny did not hear any adventitious sound. Jenny, did you hear any grunting?
No grunting.
Any retractions?
No retractions.
Show them where retractions would be, Jenny. See that
Retractions.
pulling?
You can pull right here, subcostal,
Mm-hmm.
and then intercostal would be in between, and then you can have substernal
Mm-hmm.
under here.
Just for them trying to get air.
Yeah, trying to get air.
And then nasal flaring, any nasal flaring, Jenny?
No nasal flaring.
So we're looking good. And our baby is nice and warm. Since our baby is under the warmer right now as we're doing this assessment, that's awesome. If our baby had any of those issues, we would definitely check a glucose. As we know, our baby would work hard and it could burn the glucose. Okay, so our breast, our nipples look nice, Jenny. We can see our baby's nice and term. Jenny's palpating the size of the nipples. You can see that they're everted, and there's a nice mound of tissue. And you guys, that's as they age and they're exposed to estrogen, they have a nice everted nipple. Breast tissue is elevated in 3 to 10 millimeters. And Jenny, do you see any nipple discharge from the baby?
No nipple discharge.
Nope. So as moms have an acute drop in estrogen when they deliver the baby and they deliver the placenta, that makes the prolactin rise so that she can start to breastfeed. Same thing with the baby. The baby may have some discharge, which is termed witch's milk, and it's just from the change in the hormone, and it will usually go away. And we do not encourage the parents, if they find this, to continue to assess it, because that will make more come. All right, so now the cardiovascular system, we've already taken our vital signs, and Jenny is now going to listen in all areas. We're first going to do aortic. Then we're going to move over to pulmonic. And pulmonic is usually where you would hear a murmur if you heard one. This is usually the ductus arteriosus, and it could be closing. It usually closes within 48 hours. Of course, a murmur is turbulent blood flow, and as that duct closes, that's when you hear it. Now Jenny's going to go down to tricuspid, and then mitral, right under the nipple. Very good, Jenny. So, did you hear any murmurs, Jenny?
No murmurs.
All right, very good. If we did hear a murmur, we wouldn't be super concerned, because it can be some of the ducts closing up, because, of course, the ductus arteriosus, which is our most important one. Now we're going to check for peripheral pulses, and so we first want to do our femoral pulses, and we always, when we check pulses, we always check right to left. So Jenny's going to put our nice little baby's arms back. Yep, there you go, Jenny, so that we can get our hands on our pulses.
Here.
Yep. Right above the elbow, we can get our brachial pulses, and we want to make sure that those are even. Are those nice and even, Jenny?
Nice and even.
Okay, good. So you want them to be +1 to +2. Usually they're +1. And then our femoral pulses. And Jenny's going to palpate. Now these can be much more difficult to feel because of the sub-Q tissue. Many times you have to go deep and then let your fingers off to be able to feel the pulses. And how are our femoral pulses, Jenny? +1?
Yep,
Are they
+1, equal.
Okay, great, awesome. Very good, thank you, Jenny. And as you can see, Jenny is putting the diaper back on underneath the cord, because we don't want our cord to ever get wet. So see how she turned it down, and so our cord is sticking out so it can stay nice and dry. So now Jenny's going to inspect the abdomen. Looks nice and round. Jenny, do you see any areas that are of concern or note? Nice and round?
Nice and
Is
round.
it soft?
Very soft.
Okay, great. We like a nice soft abdomen. And then, Jenny, do you want to count your vessels in your cord? Can you see them still?
Kind of difficult, but I see
3 vessels. Do you see 2
do.
arteries in a
I
vein?
see 2 arteries in a vein.
Okay, awesome. That's what we want to see. We know that the vein delivered the oxygen and the nutrients to the baby, and we know that the 2 arteries carried back the waste products and the CO2 to mom to get rid of. Okay, bowel sounds. You want to go ahead and do your bowel sounds,
Sure.
Jenny? So we're just going to do bilaterally, and we're just going to listen to bowel sounds. And normally we can hear these pretty rapidly. Already, Jenny?
Baby's
So
hungry.
quick. Yes, babies are always hungry. And when Jenny palpated, there were no masses, so we did really well there. Okay, next is musculoskeletal. We can see our baby is nice and flexed. We see our knees are well flexed. Our baby's not flaccid. Our baby's not hypertonic, which would indicate potentially withdrawing from drugs from the mother. So our baby looks nice, looks very nice. Our symmetry of movement is equal. That means the right side and the left side, very symmetric. Next we're going to check our hips and our gluteal folds. So when we look at our baby's hips, the first thing we can do is knee height, and we're going to see are our knees the same height. And as Jenny pulls them together, we can see our knees are the same height. That would mean that our trochanters are both well seated in the pelvis, and that we are not suspicious of a congenital hip malformation. Next, she's going to look at the gluteal folds, and she's going to pull the knees back. And we're going to see, do the gluteal folds, are the folds of the buttocks look even? And we can see on our baby, they look nice and even. Yeah, it's very nice. So that's good. Ortolani's maneuver is just simply, Jenny's just going to roll them around and make sure that they're nice and smooth. Yeah, very good, Jenny. Nice and smooth, that we don't feel anything clunking, falling out. Everything is nice and smooth and symmetric. Great. Next, we're going to check our clavicle integrity. Jenny's just going to take her fingers and go along the clavicle to make sure that we don't have a fractured clavicle. And what a fractured clavicle feel like is just a little tiny bump. So don't expect to feel anything major other than asymmetry and a little bump. Next, Jenny's going to roll the baby over and look at the spine. And she's going to take her finger and trace along to make sure the spine is nice and straight. And then she's going to separate the buttocks and look for a sacral dimple. It is very common to see a sacral dimple we are not concerned as long as it is nice and closed. And as Janae's showing you, you look for that sacral dimple and then you look for the bottom of it to make sure it's nice and closed. If it were open, that can mean it can communicate with the spinal column and the canal, and that could cause us some worry. And we would definitely have that worked up. That could be a type of spina bifida occulta. So we want to, again, check the spine, make sure it's straight, look for a sacral dimple. If it's closed, we're fine. If it's not, we definitely want to report that. Then Jenny's just going to look at the hands and feet and just look at the musculoskeletal extremities, looking for any deformities or abnormalities. The most common abnormality we see is an extra digit, and many times it's right there off the pinky. Usually there's not bone, and they usually tie these off and they come off relatively easy. Next, Jenny's going to check, he is a male, so she is going to look at his penis to make sure that his meatus is centered. So you want to make sure that his meatus is centered, that it's not displaced lower or around the shaft of the penis. She's going to check for his testes to make sure that they have descended. And Jenny, did you feel both of them?
Yep, one at a time.
One at a time, yeah.
And they are both down there.
Okay, great. And then a little girl would just be a visualization. Usually if a baby is term, you're just going to see the majora, and the minora is going to be rather small. A vaginal tag or a little piece of skin is completely normal to see, and as the baby grows, that vaginal tag will recede. Of course, you want to, when you did your first rectal temperature, that's where you assess the patency of your anus, and if the probe was able to go in. Jenny's going to go ahead and show you how to do a rectal temperature right here real quick. She's going to pull the knees up, and then she put some lubrication on it. And then you hold the knees up, and she's just going to go in real quick. And you're only going to go in 2 centimeters. Ding, ding, ding. And the temperature is 99.8, Jenny. Feel good about that?
Yes, I do.
And the anus is nice and patent. You are going to see meconium stools, which are very black, thick, and sticky for the first probably 2 or 3 days. And then they're going to gradually turn into stool that looks like our stool. The nice thing about the meconium stool, though, is it's the byproduct of the GI formation, so there is no bacteria in the stool, so it has no